Hi, we are Group 10 from Stream 2. Today, our team are going to present our initial ideas for street style medics. Here are our team. We have 4 members, and this is the agenda. Now, let's begin with our first part, understanding the challenges of street style medics.
Hi, I'm Peng, and I will first present the real-world need and impact of street-side medicines. So just a brief recap of SSM, which is a GP-led mobile service offering free primary care to people experiencing homeless and other vulnerable groups across New South Wales and Victoria. They operate with 12 staff, over 400 volunteers, 5 vans, and 14 clinics. The core challenge that SSM currently faces is limited scalability, sustainable service delivery, and difficulties attracting ongoing donors and partners. The current mobile outreach model is highly resource intensive, requiring specialized volunteers like GPs and nurses, making it challenging to find, train, and retain enough of these skilled people to keep up with demand, along with budget pressure. The problem carries a significant real-world impact where vulnerable groups in our society are already faced with widespread barrier to mainstream healthcare, hence limited expansion of SSM service means more people are not able to access free healthcare, resulting in more people ending up in already stretched emergency department, which overall deteriorates and puts pressure on Australia public emergency healthcare system.
Hi, my name is Vijaya Sam. So today I'm going to talk about the secondary research. The main takeaway from our research were as follows. First, we found that barriers to healthcare are both structural and psychological. Structures include things like a lack of a permanent address to receive a Medicare card, as well as the transportation to a healthcare services. And psychological structures can include the feelings of shame or the fear of being judged. Secondly, we found that trust is essential. The research states multiple positive recurring interactions are required before the individual will use the services, and that trust can take months to develop. Finally, we found that once there is a known homeless population, they can become unreachable. This is due to the fact that they are constantly on the move, as is the need of continuity of care. The services need to be available to meet the needs at their current locations. With reference to primary research, we conducted surveys that allow for both quantitative and qualitative answers. We also did 3 in-depth interviews with a GP, a social worker, and a university student. To analyze our findings, we used empathy maps to illustrate feelings of shame or anxiety. We used journey maps to locate the barrier between the awareness and the first visit, and develop a persona. Marcus, who is a 38 years old with a chronic health condition and the distrust of the system. What we found was a large gap in the system where trust system barriers and user behavior had to be factored in. Many people will delay care due to excessive waiting time or because of the difficulty in accessing services that are perceived to be either urgent or of a little to no value.
Looking at both primary and secondary research together with the combination of various tools, one thing kept coming up, and that is trust. It is the biggest barrier stopping vulnerable and homeless people from accessing healthcare services. What we found is that these people need a safe and non-judgmental space where they can feel comfortable. And it's not just about one good experience, it takes repeated interaction over time for trust to build. So, from everything we found, trust is at the heart of it all. And that's what led us to step back and reframe our how might we statement to what actually matters most to the people we are designing for. And that's how we finally came up with this how might we statement. How might we build trust to encourage homeless and vulnerable people to access street-side medic services? To find out the best idea for our how might we question, we went through a 3-step ideation process. First, we started with divergent thinking using brainwriting method. Basically, everyone generated and expanded as many ideas as possible without any judgment. This gave us around 15 creative ideas from different perspectives. From there, we moved into convergent thinking and narrowed it down to the top 4 promising ones by voting. And finally, we used the bug matrix to evaluate and compare ideas against the 5 criteria: accessibility, language, consistency, training, and dignity and respect. The strongest top 3 ideas with highest score are community well-being, volunteering, health and well-being workshops, and support near train stations. So let's take a closer look at each of these three ideas and find out which one came out on top.
Idea number 1, community well-being volunteering, and here how it works. Step 1, street side medics. Waiting list is used to recruit volunteer depending on geography, flexible time, and languages. Step 2, background training on active listenings, empathy, and communication. Safety drills and situational vulnerability training is provided. Step 3, participants are positioned at the nearby shelter, community center, and outreach activity. Step 4, continued engagement with vulnerable community member is conducted through informal conversations and well-being check-in. Outreach volunteer wears street medics brands uniform for visibility. Step 5. Healthcare services provided by street medics are introduced and volunteer support community member is assessing medical checkup. Step 6. Outreach activity are followed by brief debrief to capture observation and assess and record progress. And this is the image represent our community well-being volunteerings. So, vulnerable population experience benefits from social ties, decreased feelings of isolation, and an increased likelihood to seek medical assistance. For street side medic, this is a measure of community impact. For DVF, it's desirable as it promotes relationship. It's feasible as it only requires the volunteers waiting list with minimal training investment. It's viable as it provides donors and grantors the impact in measurements data. It's a low-budget initiative that includes trainings, materials, and branded uniform for volunteers that estimate pilot durations is 4 weeks. The second idea is a health and well-being workshop program, and here how it works. First, arrange 1-hour workshops every week is close proximity to street medic events or community center. Second, use volunteer on a waiting list to facilitate teaching sessions on hygiene and mental health, nutrition, and first aid. Third, workshops are offered on a casual walk-in only basis, and registration is not required. Fourth, free snacks and hygiene kits are provided. Fifth, a participant card system is introduced whereby participants earn a stamps for every workshops attend, and once 3 stamps have been obtained, receive a free gift such as clothing, food vouchers, or hygiene kits. This system is designed to encourage trust building that is developed by workshops participants. Finally, during the workshop break, clinic information is shared by volunteers on a no-sales basis. After each workshop, feedbacks and attendance data is collected to measure the impact. The vulnerable group gain better understanding of health and support to access healthcare, plus improve health and the greater confidence to seek care. For street medics, this boosts community engagement, build trust and understanding, and offer partnership possibility. Analyzing DVF, it's desirable as a secure, social, and non-judgmental setting, feasible as it relies on the current volunteers and the event location at a minimal cost for 207 for each sessions, and viable as its attendance provided impact metrics to support fundraising efforts. Estimated from the start to carry out the pilot is 4 weeks.
So I'll be talking about idea 3, which is the train station support. So idea 3 is about setting up temporary outreach support station near major train stations. These stations give homeless and vulnerable people easy access to basic support, a safe place to connect with volunteers, and simple referrals to streets and medic services. The purpose is to build trust through consistent visibility in familiar public spaces. The benefits for vulnerable people are that this idea makes support more accessible, reduces transport barriers, and provide immediate practical help like water, snacks, and hygiene kits. For streets and medics, the benefits are that it increases community visibility, encourages partnership, and allows volunteers who live nearby to help regularly. In terms of DVF framework, it's highly desirable and moderately feasible because it requires station permission, because it might disturb the local people over there, and strongly viable due to low cost and scalability. So how Idea 3 works. This idea works by setting up a small outreach station outside major train stations where vulnerable people often gather and feel comfortable accessing support. As shown here, street-side medics volunteer operate a small branded booth in a busy public area near the station entrance. Before setting this up, street-side medics needs to work with council, station management, and safety officers to gain permission and ensure space is safe and accessible for everyone and not disturbing anyone around it. And volunteers are selected from streets and medics waiting list, especially people who live nearby They are all cross-trained, so they can rotate between different roles such as greeting people, providing basic well-being check-ins, and offering referrals. During these outreach hours, the booth provides simple support items like water, snack, hygiene kits, and information about available health services. Volunteers also speak with people directly. This helps to build trust through regular face-to-face interactions. And if someone needs further medical attention, volunteers can refer them to the nearest streets and medics van or clinic services. And overall, the main purpose of this is that it increases visibility, community trust, uh, strengthens community trust, and makes support easy to access in familiar public spaces. So, in the impact effort matrix, we selected Idea 2, the Health and Wellbeing Workshop Program, because it offers the strongest balance between impact and effort. Firstly, it's highly desirable. It creates a safe social environment where vulnerable community members can learn, connect, and build trust with street side medics. It is also very feasible. The program uses existing volunteers and current van locations, which means it requires minimal additional costs or resources. And importantly, it's viable. The workshop provides clear, measurable outcomes such as attendance numbers, engagement levels, and participant feedbacks, which can help attract donors, partners, and long-term support. When we compare this to our other ideas, the difference became clear. Compared to Idea 1, which is smaller scale, and Idea 3 required more logistics, coordination, and permissions. In contrast, the Idea 2 delivers high community impact while still being manageable for organization to run. Because of this, it sits in the major project quadrant of our impact effort matrix. It's realistic, scalable, and strongly aligned with Street Side Medic's mission to build trust, improve health literacy, and strengthen community relationship.
For our final recommendation, after effective consideration and evaluation of the three ideas using the PUGH matrix and impact effort matrix, our team recommends that Three-Side Medicus implement health and well-being workshop program, as we highly believe it is low cost, low risk, and can directly help with SSM's scalability challenge. It works by firstly recruiting and training volunteers to facilitate practical, hands-on workshop in safe, non-clinical space, covering basic topics like life support, wound management, emergency response, and mental health awareness, where registration is not required, allowing casual walk-in participation. The program is built on a simple promise: learn, care, respond, save lives. The workshop model is described as it addressed real community needs for health support and practical skills. It is facilitable because it uses SSM's existing volunteers and van location with minimal cost, and that is variable as it can be sustainable through grants, donations, and partnership while reducing pressure on emergency service. Overall, the approach directly addressed the primary barrier identified in our research, fear of judgment, where overall the expected outcome includes increasing return visit, stronger patient relationship, better continuing of care.
Thank you for your time and attention.